excellent presentation by both the speakers. My first question is to Professor Virendra Singh. So one thing is that the domiciliary use of albumin, do you think so the cardiac dysfunction which is present in most of the cirrhotics plays an important role in adverse outcomes? And if so, what is the level of cardiac assessment we should do before putting patients on such a albumin protocol? And second, your thoughts about the availability of 25% albumin. How does it work and where is its application most recommended?
See, I do not advocate the use of domiciliary albumin. There have been deaths because the anaphylaxis of the albumin at the home, not only at home, in hospital also. Many times we face this problem, so should not be used at the home. Then regarding the next question is
25% albumin.
25% albumin. Yes, we can use it. There is no problem in that. This is available. Takeda also is supplying 25% also. So this can very well be used. Only thing is that you have to be little careful, and the infusion should be slow. At least for 20 grams bottle of 100 ml, we should at least 2 to 3 hours, minimum 2 to 3 hours, not in 1 hour. We take slightly more time, maybe 3 hours or 4 hours, because when we drain the ascitic fluid, we start at the same time. It takes about 4 to 5 hours, and for the 5 liters, 6 liters, 7 liters. So you should be little slow.
Yeah, my question is to Dr. Virendra Singh first. The albumin which is produced in chronic liver disease, when it is in advanced stages of liver disease like hepatitis B and chronic CTP B and C, is it structurally abnormal or quantitatively abnormal, or does it get destroyed? Because that will decide how much you to replace and when to replace.
It is the functional albumin which is important. There are changes occurring in patients with the cirrhosis. So actually the effective albumin is very important. In patients with the cirrhosis decompensated, the albumin becomes dysfunctional.
Okay. And does it get destroyed because you have so many inflammatory toxins,
Yeah,
including bile acids?
it goes down as the time progresses.
And to Dr. Raki, you said that bile acid is an important component of kidney injury, especially in ACLF. So is there a corresponding corollary in patient with deep obstructive jaundice when you have high bilirubin, or cholestatic viral hepatitis, when you have similarly high bile acids, including in pregnancy, but these patients do not develop nephropathy which is related to the bile acid? So is it specifically related to liver disease, or is it just because of the degree and the extent of rise in bile acids?
Yeah, very important point which you have raised, sir. Actually, the initial diagnosis of coulommic nephropathy had dated back to measurement of bile acids and this histology in patients who had extrahepatic biliary obstruction. But the thing which drives this renal dysfunction, so we have also seen in patients who have cholestatic, pure, deep jaundice, even hepatitis E infection, which we are not seeing, but we have reported from a center where we had seen that even though the patients did not have acute or chronic liver failure, they did get that coulommic organ dysfunction. So one is that, but more often these bile acids become toxic in the setting of the systemic inflammation. So it is a circulatory dysfunction, systemic inflammation, and then the role of these bile acids and how they are driving. So just one number may not be very accurate, but yes, it may suggest that if your bile acids are elevated in ACLF, you may be dealing with the AKI, which is having a coulommic nephropathy component.
Can you pick it up in the urine? How frequently can you pick up with the urine bile?
Urine bilirubin crystals, if you ask, we see with naked eye examination, it is very nicely, and it is the best marker which tells us. And if the urine may have some renal tubule epithelial cells, bilirubin crystals, but when you see AT in patients, they are totally granular cast. And now the pathologists also give us in reporting that they're seeing bilirubin crystals, so that could be one marker to say that we are dealing with coulimic nephropathy.
Just to take this question forward, Rakhi, am I audible? Gaurav here. What you showed in your data, that there was a difference between ATN and coulimic nephropathy as far as metabolomics or urinary NGAL was concerned. Coulimic nephropathy was more closer to HRS, probably more functional. There is more bile in the body, bile is 30, there will be bile in the urine. So how is it on treatment basis, how is it different from treatment of ATN or HRS when you are treating these patients, if we are calling it a new entity? So how do we say that when structurally we are not really finding the organ damage symptoms? NGAL is not very high and the metabolomics for ATN are completely different from coulimic nephropathy.
So again, I would like to emphasize, I did not have time to show the entire set of inclusion and exclusion criteria. What we see in clinical practice is not this pure syndromes. This set of patients purely you will get, yes, in maybe 30 to 40%, but 60% will have a mixed picture, where you have bilirubin crystals, you have granular cast, so there will be a mixed phenotype. Why is it important to pick up this structural AKI in HRS is that you can ahead of time understand that you need to do something different rather than waiting for the patient's AKI to progress, and you need to add something else like an extracorporeal therapy for removing these cytokines and bile acids which are driving the renal dysfunction. So you will be expecting that your response will obviously be poor. And that is why again we are moving to that concept of dynamic assessment, not waiting at time frames of 24 or 48 hours. Look at your patients. If the hemodynamics are not improving, kidney parameters are not improving, we need to think that we may be dealing with another phenotype of AKI. And then this distinction, like I showed, the ATN patients are immunocompromised. There, if you do a therapy like plasma exchange, you may actually introduce more problems because you've removed the protective cytokines. So that is why if the inflammation is driving the renal dysfunction, that distinction is very important. CRP and other surrogates could also be very helpful in these patients.
Microphone 3. This is to Dr. Aki. Very nice talk, ma'am. So, as per the new definition of AKI HRS, there is this 24-hour window which is modified from the earlier 48 hours. So there was this earlier guideline where it was the dose of albumin was 1 gram per kg to a maximum 100 grams per day. So number one, is this still valid? Because most of our patients, at least in our government hospitals now, get like 20 to 40 gram max, even the ILBS study. And second is, ma'am, what is the strategy to monitor these patients' intravascular volume? Because all these have a negative thing in patients with ascites.
So this is a key point. I dealt with a spectrum where we were dealing with volume non-response because of the time limit. I could not discuss the volume response part, but what you're saying again is very important, and slowly and we are moving towards a personalized approach. And this is what in the APASL guidelines we've clearly mentioned, that you have to do a response-guided albumin assessment using IVC or some form of dynamic indices, like if you can do a lung ultrasound. So you should assess these patients every 6 hourly. The choice of albumin would also vary based on the volume status. And again, when do you need to stop or de-escalate your albumin is also very important. And you should not continue it to the entire management of your AKI. So it should change based on the volume status of the patient.
Yeah, Dr. Rakesh, please.
So, Dr. Aki, excellent talk. The way I understand about any crystal formation is when there is a solid and a solvent, when the concentration increases, crystals will form. How do we define coulimic nephropathy purely based on the presence of crystals? Right? If there is a good filtration, so bilirubin filters, and then there is good reabsorption, then the crystals will form. How, just based on presence of crystals, how do we define a new entity and say that this is nephropathy and not just presence of crystals?
Yes. Again, sir, it's a very important point again which you raised, and we see that you will see, and if you start seeing the urine microscopy, even in patients who are deeply jaundiced ACLF, not having AKI, you may see crystals there also. So that also we have seen, we have not published, but we see that crystals can be there. But when you're dealing with an AKI and you get these crystals, that means the kidneys have got affected and there is a role to understand those kidneys in this context, as the bile acids or bile salts are driving renal dysfunction.
What is the morphological counterpart of this colemic nephropathy? What would you see in the kidney tissue in forms of an injury?
So kidney tissue, we see bile casts in the distal tubules, starting from the distal tubules, then in the proximal tubules. So you see that bile cast nephropathy is the classical name. Thank you, sir.
Yeah, Dr. Mukul, please.
Yeah, two questions with Dr. Raki. So AKI and ACLF is a totally different variety of AKI. So colemic nephropathy. So what would be the better treatment for colemic nephropathy? It is CRRT or plasmapheresis, number one. And number two, this colemic nephropathy is converted into a structural variety of AKI in future or not? What is the evidence of CKD in such patients?
So another very important point. So when you're dealing with a patient in the ICU, where there is circulatory dysfunction, 1 or 2 organ failures. So you have kidney plus 1 more organ failure. These are the patients where you can actually look, and classically colemic nephropathy patients, because we've done this study, we see they are non-oliguric. So they will be having very high creatinine, but they will be producing good urine because there is a concentration defect in the kidneys, and they keep producing urine in advanced stages. So such patients, you may still consider Plex or something to remove bile acids, because CRRT will not improve that. But if you're dealing with more of ATN or a mixed colemic ATN phenotype, it is better to use CRRT because it's much more safer.
And what about future structural development of structural AKI in colemic nephropathy?
Yes, so that study has not been done, but we expect if we diagnose them, because most of these patients die in the absence of liver transplant. So it is a transplant group. Post-transplant outcomes, I totally believe that colemic will have better outcomes despite these patients being taken up on an RRT as compared to ATN, where the progression of kidneys would be higher. But that data should come from the transplant group.
Thank you.
Thank you, chairpersons.
Thank you, Dr. Raki. Thank you, Dr. Virendra, for excellent presentations, and my co-chairs. We'll close the session now. Thank you.